Today I'll speak about symptoms and investigations for kidney diseases. What are the common clinical presentations in patients presenting with renal problem? CKD can be typically identified through routine screening with serum chemistry and urine studies, or as incidental finding, which is very common in our patient. Less commonly, patients may present with symptoms such as gross hematuria, foamy urine, nocturia, flank pain, and decreased urine output. If CKD is advanced, so the effect of uremia will greatly impact the patient, and the patient will present with extreme fatigue, nausea, vomiting, poor appetite, muscle cramps, altered mental status with confusion or trouble concentrating, swelling, and dry or itchy skin. What are the additional questions you have to pose to the patient? You have to ask about the presence of comorbidities like hypertension, diabetes, autoimmune disease, and chronic infections. You have to ask about symptoms that might suggest a systemic cause, including hemoptysis, rash, lymphadenopathy, hearing loss, urinary hesitancy, urgency, frequency, so urinary tract symptoms, and risk factor for kidney disease if the patient is taking nephrotoxic medication like non-steroidal anti-inflammatory drugs, herbal remedies, antibiotics such as gentamicin and chemotherapies, history of recurrent stones, family history of kidney disease. On physical examination, you might have a patient with signs of either volume overload or volume depletion, flank pain or enlarged kidney on examination, neuropathy, which may be either related to diabetes, vasculitis, amyloidosis, for example, skin findings like rash in SLE, palpable purpura, if present, might indicate the coexistence of vasculitis, telangiectasia in scleroderma, extensive sclerosis in scleroderma. All of these diseases might have an impact on the kidney. Patients with advanced CKD may show signs of pallor related to anemia, muscle wasting, myoclonic jerk, altered mental status, and precardial rub. Retinopathy also can be found on retina examination, especially if he is a diabetic patient. Patient with carotid or abdominal pre-carotid carotid B can be related to atherosclerosis with an increased risk in renal patient due to the coexistence of multiple comorbidities, and abdominal pre might indicate renal artery stenosis. So the patient is CKD or not? This is a common question posed by the patient. Do I have a chronic problem, or it is just a sudden and reversible increase in renal function test? So in order to say that the patient has CKD, by definition, the patient should have abnormalities of kidney function or structure present for more than 3 months. This includes all people with markers of kidney damage and those with an eGFR of less than 60 ml per minute on at least 2 occasions separated by a period of at least 90 days. So an eGFR of less than 60 ml on 2 occasions separated by a period of at least 90 days with or without markers of kidney damage confirm the presence of CKD. So what are the markers of CKD? This include albuminuria, defined as an albumin to creatinine ratio less than 30 mg per millimole, urinary sediment abnormalities, histological diagnosis of CKD, structural abnormalities detected by imaging on ultrasound. So if you say that the patient by definition has CKD, the second question is, at what stage of CKD is your patient? So we all know that CKD is categorized into 5 stages, from stage 1 to stage 5 based on eGFR estimation, but also on the albuminuria category to A1, A2, A3. A1 less than 30 mg per gram of albuminuria, A2 moderately increased from 30 to 300, and A3 was severely increased more than 300 mg per gram. So the eGFR interpretation is usually done with an estimated equation, but you have to take into consideration that creatinine can have some fallacies, especially in patients with extreme of muscle mass. Reduced muscle mass will lead to overestimation, and increased muscle mass lead to underestimation of the GFR. So as a general advice, you have to advise the patient not to eat any meat in the 12 hours before having a blood test for EGFR estimation. This is one of the commonly used equations, CKD epidemiology equation, which take into consideration the gender, the race, the age, and serum creatinine of the patient. You have to confirm an EGFR of less than 60 ml per minute in an adult not previously tested by repeating the test within 2 weeks. How do we test for albuminuria? At first, we do the urine analysis, and by the reagent strip, it will give you in a semi-quantitative manner either 1 plus, 2 plus, 3 plus of albumin in the urine. But commonly, we do a quantitative measurement through either 24-hour urinary collection or albumin to creatinine ratio. This is the example of the reagent strip used for detecting albuminuria in urine analysis. So it will give you a rough semi-quantitative estimation of the quantity of albumin. For example, 1 plus, approximately you will have 0.3 gram per liter of albuminuria, 2 plus 1 gram, and so on. So you have to confirm this with an albumin creatinine ratio done in the first morning sample, which is more practical than the 24-hour urinary collection, which is liable for either over or under collection of albumin estimation. A recommended group for measuring proteinuria with urinary albumin creatinine ratio are adult patients with diabetes, either type 1 or type 2, adult with an EGFR of less than 60 ml per minute, adult with an EGFR of 60 ml per minute or more if there is a strong suspicion of CKD. So, you can confirm CKD by the above mentioned items, but also you have to proceed forward if you didn't still confirm the presence of CKD, and as a part of your workup, you have of course to do a urine analysis, which can give you an idea about a nephritic presentation. Of course, the patient clinically will present with a high blood pressure, altered color of the urine, brownish color of the urine, mild edema, but of course on urine analysis examination you will find a leukocytic count or pus exceeding the normal values, RBCs and RBCs cost. While the nephrotic presentation, the patient of course will present with generalized edema, hypoalbuminemia, albuminuria exceeding 3.5 grams, and on urine analysis you might have lipid cost, slight RBCs, even sometimes no hematuria, leukocyte, and on protein estimation you will give you the data of the reagent strip, which might be 3, 4 pluses, indicating the need for doing a quantification through the albumin creatinine ratio or 24-hour urinary collection. One of the presentation, patient might present with UTI. You will show signs and symptoms of urinary tract infection, and on urine analysis you will find pus exceeding the 100 leukocytic cost, and of course you will have to correlate this with the patient clinically and perform urine culture and give appropriate antibiotic treatment. Further, we have to continue our lab investigation, which might give you an idea about roughly either a patient is presenting with acute or chronic problem. For example, if the patient have an elevated serum PTH, low hemoglobin level, usually it goes toward a chronic kidney disease. And of course, we have to check electrolytes, especially the calcium, which if low indicate also an element of chronicity. The ABG also is very important in order to estimate the acid-base balance and to find the degree of metabolic acidosis present in our patient, but you have also to check the oxygen saturation of the patient, as most of our patients might present with signs of volume overload. Ultrasound, so we'll pass to imaging studies. Of course, normal kidney will have a good corticomedullary differentiation, good echogenicity, and good size, while in CKD patient you have an atrophic kidneys with increased echogenicity and absent corticomedullary differentiation. Also, it might orient toward other causes of CKD, which might be autosomal dominant polycystic kidney disease. As you can see, the kidney is replaced by multiple cysts. And of course, it is very important to make the diagnosis of and to exclude the presence of obstructive uropathy, as it will have, as you will have to do an immediate intervention. So when to proceed to a renal biopsy, hematuria of unknown cause, persistent non-orthostatic proteinuria, RPGN, nephrotic syndrome resistant to steroids, suspected familial nephritis, SLE for example, monitor the course of JN in response to treatment. And the renal biopsy, you will have to, by optic microscopy, light microscopy, electron microscopy, to find if there is any immune deposit, and sometimes we have the need to do electron microscopy to confirm your diagnosis. What are the common case scenarios in nephrology? Common case scenarios, of course, patient, especially old age patient with signs and symptoms of dehydration, either through vomiting, diarrhea, overuse of diuretics, and of course, the patient might have a presentation of either AKI or AKI on top of CKD. Good fluid resuscitation with adequate urine output estimation, you might have a very good response and either return to the baseline serum creatinine or even return to normal renal function according to the case scenario. Signs of volume overload. Of course, of patients might present with volume overload. They might have coexistent heart failure or presenting with nephrotic syndrome. The volume overload can be just lower lymphedema. It might progress to ascites, pleural effusion. So appropriate evaluation is very important. Measurement of serum albumin is very important. Evaluation of his cardiac condition is very important. And the prescription of appropriate dose of diuretics together with a fluid balance for the intake and output will help the patient to achieve his euvolemic state. The third case scenario, which is very important, is to exclude the presence of obstructive uropathy. And of course, a very important item in our evaluation is to do renal ultrasound. So if you find there is a back pressure on the kidney and hydronephrosis, an urgent call to the urologist for either percutaneous nephrostomy or the insertion of double J, of course, after doing a CT to identify the cause of hydronephrosis. If adequately and rapidly treated, the patient might return to his normal renal function test. So obstructive uropathy is a very common presentation which needs a very rapid evaluation and appropriate and immediate intervention by urologist. The last question, who should be tested for CKD? You have to monitor the eGFR annually in adults who are taking medicines that can adversely affect kidney function. You have to offer testing for CKD using eGFR, creatinine, and albumin creatinine ratio to adults with any of the following risk factors, including diabetes, hypertension, previous episode of AKI, cardiovascular disease, structural renal tract disease, recurrent stone formation, for example, multi-system disease with potential kidney involvement, gout, family history of end-stage renal disease, incidental detection of hematuria or proteinuria. You have to monitor also adults for the development or progression of CKD for at least 3 years after AKI, even if the estimated GFR has returned to baseline. And thank you.